we can probably start. I welcome you to the Medical Assistant Treatment Overview. My name is Edith Cook. I am one of the founders of A New Tomorrow and Pillars of Empowerment, the building you're in right now. So I just wanted to give you a little history at the beginning of methadone treatment. In 1996, researchers, physician Dr. Vincent Dole and Dr. Marie Noswander pioneered methadone maintenance treatment in New York City. At a time where heroin addiction, many believe addiction was primarily a moral failing. Dole and Noswander introduced a different perspective. Opioid addiction was a chronic medical condition that could be stabilized with medication. So their research showed that it will reduce heroin use, prevent withdrawal symptoms, and decrease cravings, allow individuals to function normal in a daily life. So in the 1970s, methadone maintenance programs expanded across the United States. Federal regulations were introduced to oversee them. And they came up with dosing standard, clinic licensing and monitoring and compliance, and counseling requirements. And methadone clinics began highly structured due to concerns about diversity and safety. So that's kind of the history. So I'm a recovering addict. So when I came into treatment, we came from a space where complete abstinence was only accepted. If you were on methadone, it was kind of frowned upon. Well, we're in a new age and era now. And methadone's assisted treatment is highly acceptable now. And it's kind of a way to help people, like they said in the early 1960s, the same things still apply to help people live normal lives. Okay, so I'll bring it this way. What is medical assistant treatment, MAT? Medical assistant treatment is most effective when it is paired with strong counseling and a supportive service. While medications address the physical aspect of substance use, counseling and support address the behavioral, emotional, and social factors that influence long-term recovery. So basically, to me, I worked for a couple of MAT clinics, and I've watched people come in and they would get their dose and they will find a way to just leave. So we came up with a plan to hold them and not allow them to dose until they had their counseling. Because if we're dealing with the methadone to prevent the cravings, what are we doing with the behavioral part? What are we doing with the behavioral part? Because that's very important for a person's lifestyle to start changing. They don't have the counseling, they might as well just go to a hospital and receive it. So the counseling part was very important. Let me go to the next, I don't want to get too far ahead of what the, addressing more than just the physical dependent. And that's kind of where I was at. MAT medications such as buprenorphine and methadone, naltrexone helps reduce cravings and withdrawal symptoms. However, substance use is often connected to a deeper issue such as trauma, stress, mental health conditions, and emotional triggers. Counseling provides a space to explore underlying cause of substance use, develop coping strategies, build emotional regulation skills. Without this component, the root cause of use may remain unaddressed. I don't know if you might have anything you want to say in that part, but that's kind of where I was leading to. So when you deal with a patient who's dealing with all sorts of trauma, preventive things that started their addiction, if they're never having the counseling, they're not dealing with those issues. They're just being medicated and moving on. And their behavior's not changing. And if you watch them, their behavior don't change. It's almost like the term where we used to use like dry drunks.
Dry drunk, that's what I'm thinking. Yeah.
It was almost like that term. And because counseling allows them to sit there and unpack. And you couldn't even imagine like the small thing and how it led to the underlying thing. And I would have them come in, and sometimes they be like, I really don't have this to do today, meaning the session. And I was like, well, let's just talk about how your day's going. Give me 15 minutes top, just to talk about how your day's going. They get in there, they're in there 45 minutes talking about something. And just that little conversation tapped into the root cause. And then I was like, okay, so can we sign up to do this again next week before you dose? Maybe like, you don't feel that bad, maybe so. Because when they feel like they're chained to a facility, because methadone a lot of times doesn't allow you to do normal things that people do. But if we can set it up where they can get 30 days dosage, and what I mean, they only come to the clinic every 30 days and they have take homes. And when you can set them up like that, and you can say, if you do your counseling, we can get you where you get 30 days take home, and then we can start increasing it 60-day take home and giving them some freedom to live life and go on vacations and things of that nature, so they buy into the counseling. Sometimes we have to get tricky. And I love that fact because there's not a cookie cutter. It doesn't fit everyone, but you find out, when you get to know your patient, you get to know your client, you get to know what works for them. And as long as we don't stray away from the rules or everything, the meat I like to use, it works out. To the next screen. Improving retention and engaging in treatment, which is, I'm ahead of myself. Okay, individuals who receive counseling alongside MAT are more likely to stay engaged in treatment, attend appointments consistently, be honest about challenges, including returns to use. Supportive relationships with counselors and staff create accountability and trust, which are critical for retention. One of the strongest predicators of successful outcomes. So basically, when we're building a healthy relationship, and when they trust you, it takes time to build trust. Sometimes we think as a clinician and a client that's an automatic, and it's not. It's not. And they get a feel for you. And some of them would come and say, I really want to change counselors because we're not working out. And I used to sometimes think it was color. I used to think it was color. And when I found out it wasn't color, it was the approach. You know, I have a still face, and sometimes I had to smile. But that they know that I could be firm on what I stand for and helping you, but I needed to present a kindness that would let you know that it was okay to talk with me. And I didn't make it based on my rules, I set it up based on their rules. And if they would say, this is the day that I could get there for my appointment, I wouldn't say this is the only time I have open. So I had to start saying, okay, let me see if I could switch some things around, and I had to meet them where they were. And we talk about meeting our clients where they're at. And you wouldn't, like, I can't even tell you how a small schedule change where they're leading can make a big difference. Because they would say, well, let's schedule before I leave. Now I want to, but to have them enforce it was a big deal for me. Okay. Okay, recovery is not only about stopping substance use, but also about rebuilding a relationship, building a stable and meaningful life. Counseling helps individuals set realistic goals, improve decision-making, strengthen relationships, navigate employment, housing, and legal challenges. These skills support long-term independence and reduce a likelihood of relapse. Now, you probably look and say, navigate employment and housing and legal challenges? If they don't have anywhere to live, they're not coming for their dose. They're not coming to talk, because that's a more pressing issue. So sometimes we may appear like a social worker. We start looking up resources to help them find housing. They might have a legal issue. We might have to reference them to places where they can go get some help with that. You know, like they can come for one thing, but sometimes when they present another need, we may have to assist. Am I making sense? Okay. Because when they're able to take care of some of those pressing things, like we used to have homeless people come, and they used to say, well, they are not consistent coming. We have to, like if they would miss an appointment in their 30-day take-home, oh, they became homeless. They would not let them have their 30-day take-homes because you have to have somewhere to store it, state regulations. So they would take them. Then we found out if they could use daily bread as an address, like people do for their Social Security checks, a lot of homeless people, mail go to daily bread. They can get their take-homes. So we figured that out, and it started working until they found housing. And so we had social workers in the building that started assisting with those things. I feel like I'm just talking. No. Reducing stigma, increasing self-worth. Many individuals in MAT face stigma from society, family, and even within the healthcare setting. Counseling provides non-judgmental environments, validation and encouragement, support in rebuilding identity and self-esteem. When individuals feel respect and value, they are more likely to retain committed to their recovery. I agree with that 100%. 100%. I had a guy who was a school teacher. Go figure. For him to be in the methadone clinic, I would hear people say, he's teaching our children. Can you imagine him on dope and you know that? And you would not believe sometimes the stigma comes from the people providing the service. From the people providing the service. I'm gonna say it twice. And we have to be careful. We have to be careful. And he already felt the heaviness because of his degree, and he was still allowed to teach. And he never had a criminal activity, but he admitted that he was using and he needed some help. So here he's coming to the methadone clinic and he's still teaching. And we started engaging and we started having conversations. And I started asking him, you know, since his recovery, like what's on his bucket list he hasn't done? He said, I haven't been on a vacation. I said, why don't we plan a vacation and get you some take home so you can go on this vacation? He went on the vacation. Then we started tapping in his bucket list. I was building his encouragement and engaging with him in a way to build his self-worth all over again. So he came to me maybe a year later and said, I'm ready to taper off. Because at first he was like, I want to do a blind taper. And a blind taper is when they don't know what their dose is, but they're just coming to dose. I said, why are we going in the blind? Let's see it for what it's worth. If we're making this commitment, let's look at it and let's see what you're dosing and let's make that decision based off what you see, because this is really about you. And he said, I didn't think about it like that. So he just started looking at every day, and we planned his taper out a year, and I had him journal while he was in a taping off process. Now, clinics don't want you to taper off. However, when a person feels ready, we need to assist them to make sure that it's done effectively. And when he finally got out, we had him come back and do peer groups. He started doing peer groups at the clinic to help other people who were wanted to taper out but were fearful of tapering out. So that's one of my little stories I love about.
I was gonna say, when I first got in the rooms, NA and AA, I sat there and you could hear the stigma. It's like, oh, that person's up there talking. They take Suboxone every day. They're not really clean. Or they go to the methadone clinic. And it was almost like, okay, we can't really talk about what's really going on because we're going to get that stigma of we're not really clean or, certain stuff like that. And I remember until I had to get to that point where I was on MAT. And I was one of those people like, oh no, they're not clean. I'm sitting here doing nothing, feeling normal, but they're taking the MAT, look at them, they're just, trying to get around stuff. And then it came to me doing it. I'm like, oh my God, I was one of those people that were talking about that person doing those things and how quickly that can happen, very quickly. And people might not look at help because they're afraid of the stigma and be like, oh my gosh, I can't get help. These people can't know I'm doing something like this, even though it's probably one of the best things I've done to get myself to where I am today and eventually off of it and all that kind of stuff. But the stigma was real, and you don't really think about that or hear about it until you're actually hearing people talk about it. And I think that stinks, because a lot of people I think are deterred from doing stuff like that because they're afraid of what people are going to think.
Absolutely, and let's talk about they're saying it. They're saying it. The client is making that confession. And I had to say to him, you're clean. You're clean. Yeah. You're not committing crimes. You're not down in Kensington or somewhere buying dope. You're not, you're clean. And you gotta believe that you are. Look at your life. A lot of things have changed. So it is hard.
Yeah, and I think one thing it showed me too is that was my problem. I was so worried about what other people thought. That's why I was in addiction to begin with.
Come on.
You used all this to show me this is why I was here.
Yeah.
Because I was so worried about following and being like everyone else that I never found my true identity until I was not worried about what people thought. So it was life or death for me, and at certain times I was like, I'll pick fitting in over life. And that makes no sense, but when you realize you're like, oh my God, this was the problem.
Look,
going through all this, figured out the problem. When I was afraid of the stigma, I'm like, that's the whole problem. I'm so worried about what's going on around me, and I'm not worried about what I'm looking at in the mirror.
Yeah.
If it's going to save my life, I want to do everything I can to save my life.
Absolutely.
It doesn't matter what other people think.
I go with, I don't know who made this song, but I love it. It's hip to be square. It's hip to be square. Because I thought, too, I needed to be where people accepted me and cared for me. But we're over here dying.
It happened to me in rehab too. The first time I ever went to rehab, I was afraid to even walk around or go to a basketball game. So I'm like, oh my God, the whole town knows I'm in rehab. I got more hugs that day than I did anything. And I'm like, oh my God, but it was the brain, just all those thoughts. I thought that people were going to look at me differently when really they just want me to get better no matter what it takes.
Yeah. Wow, thank you. Support relapse prevention and harm reduction. Counseling equips individuals with tools to identify trigger high-risk situation, develop relapse prevention plans, understand harm reduction strategies. Rather than viewing relapse as a failure, counseling reframes it as a learning opportunity to help individuals return to stability quickly. So when they come into the clinic and we haven't seen them in a minute and they say, I relapse. I used to say, how do you relapse when you're taking a blocker? But they can be some of the most creative people, and they find ways to get around things. And I used to be curious to know. But anyway, if they did relapse, I would remind them of everything they learned. And let's revisit that and see how we can get back on track. And I literally sometimes would brush them off like they're in a race. Like, dust you off and get back in there, you know. Dust you off and get back in there. Because they wouldn't have information on relapse prevention if it wasn't something that might happen. It doesn't necessarily have to happen, but there's a possibility that it may. And as a provider, we have to watch our language. Oh, you did that again? Oh, you messed up? Like, they're already feeling that. They're already thinking it. So we have to be, I used to always have a blank face. I was taught that working for Cadenzia. They said you have to blank your face so they don't see what you're thinking. Even if I'm thinking, oh, this is the third time they relapse, I'm never going to say it. You're never going to see it on me. Because what good am I to them if I'm making them feel bad about what they've done? If I'm the help, if I'm assisting, I have to put my prejudices aside and what I think you should be doing. And sometimes it's hard because in relationships we get tied into clients and we want them to succeed. But whether they succeed or fail, it's not on us. So that's one thing that we have to be mindful of. Okay. Strengthen the support system. Recovery is more sustainable when individuals are connected to a supportive network. Counseling often includes family education and environment, peer support and group counseling, referral to community resources. These connections are reduce isolation and created a sense of belonging. Sometimes you will have family members come in because they would say, my family doesn't understand. To have family sessions, and I only did it if the client wanted it. If the parent would call, we had a release, and they stated, I really want to come in and know about this. And I would say to them, let me speak to Billy, Bob, or Jane first and see if that's what they want. And the parent might say, well, they don't really know what they want right now. I'd be like, oh yeah. Even when they wasn't doing what we want them to do, they know what they wanted. How about that? You know, and that's empowering them to value their family member, to value them, because sometimes with the addiction, our families can lose value for who we are until we get into a great place. But we need that support immediately if it's available. They have peer support groups that we used to do in the place I used to work. Because I came in blind to MAT when I came there and worked. I was blind to MAT. I didn't know nothing about it. I was still caught in my lane of abstinence is the only way. And they taught me various pathways. And I'm telling you, it took me a while to understand it. But when I understood it, they were like, we created a monster. Okay, MAT counseling and support are essential because they transform treatment into medically only approach into a comprehensive recovery process. While medication stabilizes the body, counseling and support rebuilds a person's life. Counseling and support rebuilds a person's life. Together, they increase retention, improve outcomes, and support lasting recovery. And I stand firm on that counseling part. That counseling part, we okay? Oh, I thought somebody was at the door. The counseling part, it's a much needed part that needs to happen.
Is that something that they're doing now? Like when I was on MAT years ago, for you to get any kind of MAT, you had to go to counseling. I think it's changed a little bit now, right? It's not a mandatory thing.
No, it's it depends on where you go.
Where you're getting your
Because when I worked for a comprehensive treatment center, you didn't get your counseling, you didn't get your dose.
Right.
Because you need both.
Yeah.
You needed both, and if you only relied on one, it's almost like giving you medication and just leaving. Now, you would never go to the doctors and the doctor just give you medication. No, you would have to see the doctor, have a conversation with the doctor, explain some issues before he will provide you with medication. And even if you already talked about a current condition and you came to get medication, after a point in time, the doctor needs to lay eye on you, correct?
Yeah.
Same thing with MAT. We still have to lay eye on our patients. You cannot. If they would call me and say, Ms. Cook, I need an increase, that's a session. That's a counseling session. Because I need to lay eyes on you and I need to find out what's the increase about. What's happening with your body? What's going on with you? I was so involved, I would go over to the doctor. Because sometimes they would try to skip the counselor and go straight to the doctor. So I would get over in the doctor's ear and say, if Billy Bob come for an increase, call me over because we need to talk about this. But I would go ahead of them. And the doctor got to a place where he said, well, if Ms. Cook says, we can increase it, because I forced the doctor to look at the issue, why they needed the increase. If you're increasing because of pain, you might need to go to pain management. That's not a reason to increase. And you'll find in methadone clinics, sometimes people want increases because they're in pain. But sometimes if you get too much of an increase, you can't function. And I have to, and it's our responsibility to make sure you can function. Because you ever see a person on methadone and they're like this? And that's where the stigma is coming from, because people believe you're still high. They're not really high. They're just overdosed on their medication, and it's creating something that looks like a nod. But if you can't stand and balance, I'm not increasing you. Even when they come for a decrease, a counseling session. I want to know why. Because sometimes when they're decreasing, they're using. But it all ties into a session. Let's talk about it. Let me lay eyes on you. Let me include the doctor in there, because I don't have a degree in doctor. I'm not a doctor. So it takes like a group. And that's your support. That's some of your support. And your support is not just outside family. Your support's in the clinic as well. If that makes sense. Oh, why MAT-related differences? Dependent is different. Unlike illicit opioid use, MAT medications are prescribed, monitored medical providers, taken at controlled, consistent dose. We just talked about that. Intended to reduce cravings and prevent withdrawal. So, like I was saying, if they needed increases because they're starting to crave a little bit more, that's understandable. But if it's just because I'm in pain, that might be more of a doctor-related issue. Associated with improved function, work, relationships, and stability. This type of dependence is similar to taking medication for chronic conditions like diabetes or hypertension. It is managed, safe, and purposeful. Addressing the stigma around substituting one drug for another. Common misconception is that MAT replaces one addiction with another. In reality, MAT reduces overdose risk, improves treatment retention, decrease illicit opioid use, support long-term recovery outcomes. The focus shifts from chaotic, harmful use to structured, medically supervised stability. I agree with that. I agree with that. I agree with that. Because I was a person that did not believe that. I thought they were substituting one for another. And I have to be very transparent. That's how I came in that line of work. in that field. I did not believe until I really watched how it operates. And when I was educated, when I became educated on it, I understood it. So a lot of times people who are creating the stigma, they're not educated about it. And if you're in this field and you're working with people in chemical dependency, addiction anyway across the board, we have to be educated. We gotta understand what is going on. There's not just one pathway anymore. Roles of counseling and support. While medication managers and physical aspect, counseling helps individual understand their relationship with substances, build a coping skill, address trauma and mental health, develop long-term recovery goals. This combined approach ensures that dependence does not become the sole focus while a person's recovery doesn't. So, the counselor still does treatment plans. We still do treatment plans with realistic goals. And whose goals are they? Whose goals are they?
The client.
Exactly. So if a client is not involved in the treatment plan, how is it written? No, we have to cover that. There's people who write treatment plans and the clients are not even there. Or they don't have enough input. And they say, hey, this is what you're doing. Because sometimes we have so many people on our caseload, we start to make cookie cutter treatment plans. And where's the individuality at? Because if I have a client who relapsed, their treatment plan's not looking like the first one they had. I'm building off the last one they had. I'm building off their last one. Or we're going to create one based off where they say they failed at or what they stopped doing. We're going to build it from there. Right? That's another form of meeting them where they're at. Okay. Tapering and long-term use. Some individuals may choose to taper off MAT, while others may remain on it for long term. Tapering should always be a slow and medically supervised. There is no one-size-fits-all timeline. Thank you. Long-term MAT is often safe than discontinuation, especially for those at high risk of relapse. The priority is safety and stability, not rushing off medication. And I mentioned earlier that when I had clients who wanted to taper off, we planned it out almost a year. And then I gave them a journal, and we journaled every day, like where they were, what was going on, and I would have a session with them, and they would bring their journal, and they would talk about, it was like a measure. Do you still want to go forward, or do you want to stop? And if they choose to go forward, we would go forward. Any questions? All right, moving right along. Harm reduction perspective. From a harm reduction standpoint, being physically dependent on a prescribed medication is far safer than illicit opioid use. MAT significantly lowers the risk of overdose and infectious disease. Stability allows individuals to rebuild their lives. What concerns do people have about being dependent on MAT? I guess these are questions. Anybody? I think we kind of mentioned it. Say it.
The stigma that they'll face.
That's what we was going to say. Brian kind of talked about it. That's one of the concerns. And some of them, some people say to them, why are you on it so long? What's the fear? Why can't you get off? And we can't give them a timeline. That's their choice. But they hear that often from people. Well, how long have you been going to when did you stop going? They hear that.
what does it look like too with all the choices of MAT that you could pick from? You know what I mean? How would you go about talking to someone about that? Like, okay, shot, pill form, methadone, like all those kind of things. What would that look like in a session, do you think? Like,
Well, they used to had a measure, like how much opioids, how much heroin or something you use, depend on what method of MAT you might need. Because I've had people who they started out with Suboxone strips. Because they wasn't using that long, and so they had some kind of scale where they determined that, and then some people went straight to methadone. But then they had people that I saw that was on methadone and was able to reduce down to the Suboxone strip.
to switch, yeah.
But you couldn't do the other way. That didn't make sense to me. Like they were against you going from Suboxone strips to methadone, because now they're questioning why. Are you using? What's going on? It was always a why with that one. I don't know why, but yeah. I would say, how do we distinguish between dependence and addiction?
Behaviors.
Some behaviors, yeah. Yeah, because some people, there was an incident where this guy had his employment for a long time, and when I was given to him on my caseload, there was a lot of negativity came with him from some previous counselors. He's a waste of time. You don't really want to, he's just never going to get it. He's probably still using with his methadone, all kinds of stuff about him. And I really thought, for instance, he was misunderstood. And he would come in the clinic with a trench coat on because it was always cold. And we would have these sessions. And sometimes he would miss, and he wanted to keep all of his appointments. So he was at a place where they would discontinue service for him from the clinic. And I would advocate on his behalf, because even when he wouldn't show up, what he was doing different with me, he was calling, saying he couldn't make it. You know, because the job he had, if he didn't get out on a certain time, he couldn't make it to the clinic. And he never stayed clean long enough to get take-homes. So I asked them, I begged them, could we do a 4-day trial for him? Like give him 4 take-homes, and he come to the clinic 3 days. And he passed that test. Then he kept coming, and he ended up getting 30-day take-homes. And I was at a convention 5 months ago, and I saw him there. And he was clean. He went in the clinic no more, and he had been in the clinic forever. And when I seen him, he saw me, he's like, Miss Cook! And I was like, I just stood there in tears, because I remember what they said about him and what they told me about him. And sometimes our clients just need us to go on a limb and argue the case. Let's give him something, because if he can hold down his job, and he worked for the state, he had a good job. If he can hold down his job and where he was living, we need to figure something out here. And if he's telling me he has to make it to the clinic on his lunch break, so he had to come from downtown Harrisburg all the way to Progress Avenue within 15 to 20 minutes, he didn't have time to play. So when he missed coming to the clinic, he would use to be able to function and keep himself from being sick. Make it make sense. I said, we need to do something. They was like, oh, why are you so worried about this guy? I said, because I just feel like it's a miscommunication and a disservice to him. We need to figure something out here. And thankfully, it worked out for him. So it says, what does stability look like for someone on MAT? What does that look like?
Someone keeping their appointments, someone working, possibly, rebuilding, relationships with family, attending meetings. Many things, yeah.
Many things.
Mm-hmm.
To me, stability looks like anybody who's not dying from the use of an opioid.
Yeah.
That's what stability looks like for me. You don't have to be building family. We would like for you to do that. Mm-hmm. But if you're not using drugs and you're not taking a risk on dying, that is stability to me. Mm-hmm. You're not causing harm. You're not committing crimes. Because we got to be careful what we think it looks like. That's why the question is posed there. Right? How can we reduce stigma around MAT use? Education. Education. I think the more we're educated on MAT, the better we'll respond to people. Summary. Dependence on MAT is a medically and managed condition, not a failure. When properly used, MAT provides stability, reduce harm, and create the foundation for long-term recovery. The goal is not simply to eliminate all dependence, but to support safe, functional, and meaningful lives. Conclusion. Medical assisted treatment, MAT, combine the benefits of medication with counseling and support, helps individuals manage cravings, reduce withdrawal symptoms, and stabilize their life. MAT improves treatment retention, lower the risk of overdose, supports long-term recovery, and empowers individuals to rebuild relationships, work, and community connections. By addressing both the physical and behavioral aspects of substance use, MAT provides a safe, effective, holistic path towards sustained recovery. Any questions?
I was just going to say, when you were talking about education, someone really broke it down very simple to me. It's like when you go and if you break your leg and you go to the hospital and they give you crutches, you're meeting with people to make sure when those crutches can come off, right?
Absolutely.
And that's what really kind of made me, and it's the easiest way I can kind of talk to someone about certain things like that. They have an issue right now and they need some crutches. And the doctors and counselors and that person will decide when the crutches come off, not any facility or any kind of things like this. Because I think sometimes we're quick to be like, oh, no, you don't need those crutches anymore. Well, who are we to tell them that? Mm-hmm. If it's working, I would rather see someone on MAT the rest of their life than die of an overdose at any point in their life. Right? But I think sometimes the stigma is, no, it's just a crutch. You need to pull those crutches out sometime. Well, do you? And that's individualized instead of cookie cutter, like you said. There's a lot of cookie cutter stuff that can't be. And we got to get rid of the cookie cutters because what worked for me might not work for anybody
Absolutely.
else. Yeah.
MAT is one of the most creative individuality form of treatment. What worked for one don't work for the other one. And you have to, to me, sit with the team sometime and discuss options of things that might work. When we're I know when I worked in the field and we just dealt with abstinence, to me that was easy because it was no drug,
no option.
Remain from all, everything, 10 meetings, do this, do that. Then you got people who don't really want to do all that. So do we say that they're not recovering? Their life don't deserve to have some kind of change happen? Yeah, I was convicted. But when I learned about it, I became more empathetic. I became more passionate about, it dissolved my stigmatism I had about people on MAT. I learned to respect them. I learned to look at their recovery like I looked at my recovery. One day at a time. So, any other?
I think it's ever evolving too.
It's ever evolving, yes.
So, I was a Suboxone guy. I wish they would have had a shot back then because, of course, me, I'm either taking my Suboxone if I can't find drug, or if I can find drug, or I'm not taking it if I can find drugs, and then I'm selling the rest of the script that they're giving me, and the habit forming of doing something every day. So we've seen in our facility with the Supplicate shot is working very well because people are getting rid of certain habits, like the day-to-day stuff.
Right.
You know, or the scared of the withdrawal. I remember trying to get off Suboxone, I was down to like an eighth of a piece, and it mentally was more than probably physically. But when I get down that low, I never could get off of it completely. You know, and with the shot and those kind of things, it kind of eliminates some of those things that were causing people to go different ways, which is really awesome to see too. You know, and hopefully it keeps evolving where it makes it easier and people don't have to worry about picking up another habit or something while trying to get better. Yeah.
Yeah, so like one of the biggest MATs right now, and I thought I had it on here, but is medical marijuana. Medical marijuana. And you know, we have the clinics, you know, and when people have medical marijuana cards, they're supposed to go to the clinic. So and then you see some of them go back to leaf. And they're supposed to go to the centers to pick up their medication, but they go back to leave. And a lot of them, as soon as they get off, as soon as they start having, as soon as they come from being incarcerated, let me use that example, what I've been seeing. When they have emotional problems, the first thing they say was, go get a medical marijuana card. Like, it's like somebody's encouraging them instead of them deciding.
And who would ever thought you would see the judicial system encouraging?
Who would think
It's
that?
very rampant right
So
now. We
now,
don't know that yet.
right now, and then now they're trying to stop it.
Yeah.
I think it should be a person's choice if they want to get on it. If they're having medical issues or physical, mental health, or need some type of support like that, I think it should be their doing and their choice, not someone just saying, hey, just go get your card, because if you're going to do something, this is what you're allowed to do.
When I was in my addiction, I was at a rehab, and I came home and I checked in with my PO, and he's like, did they say anything about putting you on Suboxone? And I'm like, That idea was played not by the facility, it was more my probation officer. And I don't know if it was just something to try to help me, but in my mind, I'm like, they didn't. But that's a good way for me to feel good for a little bit, and then maybe try to, because it wasn't my idea, because I really didn't want to do something like that. But someone that was overseeing me, I'm like, oh, that's a good idea. I will get on Suboxone, and then it led to a crazy, even crazier lifestyle, kind of, yeah. But that was embedded, and I can see that with what's going on now with medical marijuana, too.
Yeah, because we're like, if you're gonna utilize it, you need to go to the clinic regularly, and we need to see your visits and things of that nature. We hold them accountable to it. If this is what you're using, this is what it needs to be. And so, any questions or any concerns, anything you want to talk about? We still got plenty of time. Okay, so we had pre and post, it's not on the screen, but I guess I could go over it. It says, what is the main goal of medical assisted treatment for substance use disorder? A, to punish a patient for drug misuse. B, to detox the body without follow-up care. C, to combine medication and behavioral therapy for effective recovery. Or D, to eliminate the needs for counseling. C, to combine medication and behavioral therapy for effective recovery. Question number 2, which of the following is a commonly used medication for opioid-dependent treatment? Ibuprofen, methadone, aspirin, buprenorphine. Do y'all have that?
No, we have paracetamol,
Yeah, we have
not buprenorphine.
we don't have buprenorphine on the last one. We have the other ones, and so it's
Okay. Okay. Which one is it?
Probably methadone, right?
Methadone.
It's methadone. Okay. She said I sent her 2 of them, maybe. Okay. True or false? MAT treatment only involves taking medication. Oh, y'all have those in your packet?
Yeah, we have them. Yeah.
Oh, okay. So it has the answer already on it?
No.
Oh, okay, okay. True or false? MAT treatment only involves taking medication. False. We talked about that. We talked about what else it involves.
Counseling. Yep.
Counseling. Okay. Why is counseling an important part of medical assistant treatment? A, it provides no benefit to the patient. B, it supports behavioral change and prevents relapse. C, it replaces the need for medication. D, it focuses only on physical withdrawal symptoms. B, it supports behavioral change and prevents relapse. 5, what kind of healthcare professional is usually responsible for administering or overseeing MAT? A, a pharmacist only. B, a registered nurse or physician. C, a social worker without training. D, a dietitian.
B.
Registered nurse or physician. Yes. Okay, did they give you the post-test? Okay, post-test. Explain how medical assistant treatment helps individual recovering from substance use disorder.
I would say it can help with cravings. Craving-wise could be one of those.
Some of it is the habit. So like, while Sublocade injection is nice for some people because it takes away the need to do something daily.
Withdrawal symptoms?
Individuals like the daily because they were using daily, so now they have replaced that with something else.
Yep. Normalize brain function.
Yeah. Get started on a life where before you couldn't, because you couldn't figure out how to not be sick.
Right.
To be able to do those things, and it might have been so long
Yep.
of using drugs that you don't even really know how to even wake up on time and go to work and kind of put the structure back in to help you, return back to society and do what,
Yeah, good. Okay, number 2, identify 2 commonly used medications in MAT and describe their purpose. Wow.
Methadone and buprenorphine.
Methadone and buprenorphine. Okay, methadone, a long-acting opioid agonist that reduces withdrawal symptoms and cravings without producing an intense high associated with opioid misuse. Buprenorphine, a partial opioid agonist that helps decrease cravings and withdrawal symptoms while having a lower risk of misuse compared to full opioids. Number 3. I think 3. Wait a minute. Oh, okay. This is true or false again. A patient undergoing MAT should be monitored regularly, both physician or psychological process. True. True. Regular monitoring is essential to ensure treatment is effective, adjust medication if needed, and support the patient's overall well-being. That's that laying eyes. That's that laying eyes and seeing them, being able to have a conversation. 4, describe a role of a healthcare provider to ensure, healthcare provider in ensuring the success of a patient's MAT plan.
Keep their appointments and are taking their proper dose.
I would say like overviewing of like walking beside them and like walking beside them instead of behind or in front, just being beside them as you're walking through the whole process. I think that's.
Yeah. Oh, I keep thinking you want to say so.
No, I was just gonna say what he was saying, being like a support for the individual.
Yeah. So basically, adjust to medication, monitoring progress, managing side effects, providing with the coordinated counselor services, also offering ongoing support, education, encouraging the patient to stay engaged in treatment. And if it's best, definitely if it's long term. Okay, 5. Why is integrating counseling and medication important in treating opioid dependence?
You gotta address the behaviors.
Yes. Yes, because the medication can deal with the physical and the counseling and help with some of the initial reason when we start using drugs in the first place, or just to help you manage. You wanted to say something, Brian?
No, I was just thinking about, even like the topic of methadone. I was never really on methadone or anything like that. I wonder what, like, if someone uses while they're still taking methadone, does that affect their use, or does it, like, lower how they feel when they do use? Like, you know what I mean? I'm not sure how methadone kind of works like that. I know Suboxone has, like, a blocker in it. I understand the blocker. I don't, it kind of intrigues me that taking something can actually make the cravings go away.
Well, they even know medications, like they even know drugs they could take that go against the blocker. And I don't know when they use a drug while they're taking methadone, it kind of throws the blocker off and they still feel what they're feeling, but they got to use more drugs to go against the blocker. And it has like a daunting feeling on them. It's so hard for them to get back on track when that happens. And you almost gotta, when they come to the clinic, you almost gotta like triple their dose to stabilize them. And it's dangerous. It's really dangerous. And you have to have the doctor determine how much you can give them. And yeah. When it happens, this is...
The new drugs coming out now.
Yeah.
So I'm sure they're going to have to start looking at how that is affecting, is the blockers working on the xylazine and all those kind of things that are coming out.
Yeah.
Yeah.
And some of them haven't even been, some of those clinics haven't even been educated on xylazine. They're just starting to have people come in and teach them about it because they don't know what's happening, especially if you use that while you're on a blocker.
Right. Yeah.
Anything else? Okay, well, thank you for coming out and thank you for having me.